All right, so we're going to get started, and good evening and welcome to our 13th annual Lynch Syndrome Educational Workshop. It's always a pleasure to have these annual workshops, and I always look forward to them. We usually do it in March. This time we postponed it a little bit to the day after the eclipse, to April 9th, and we welcome all of you. So I wanted to give you an overview of our excellent speakers for the night. So the least of all will be me. I will start off with gastrointestinal cancer risks and opportunities for immunoprevention. And then Dr. Latham will review some of the updates in Lynch syndrome. You have heard from her before in previous years. Then Dr. Liu will go over gynecological cancer risks and treatment approaches to these cancers. And then for the first time, Lisa Milley, who is one of our nurse practitioners, will review updates on what to do for menopause and women's health in general. I think this is a lecture that we very much look forward to and we haven't had before. And then also, by popular demand, all of you in your feedbacks have wanted more on integrative medicine and on what you can do in terms of lifestyle and behavior. And therefore, we are very grateful to have Dr. Mao, the chief of the Integrative Medicine Service, here to talk about the role of integrative medicine in cancer prevention and treatment. And as usual, this will be followed by a question and answer session where we will try to answer as many of your questions as we possibly can. Just in case you're interested in other topics, just remember that these educational workshops are videoed. So you can find the 11th and the 12th workshops online. If you just put in 11th Lynch Syndrome Educational Workshop, it should come up. In the 11th workshop, we addressed pancreas risk and surveillance in great detail. Dr. Rolston gave us a terrific talk on that. We talked about GYN, reducing surgeries last year, and a number of other things like exercise, optimizing lifestyle, so on and so forth. So you can always view these older workshops. We also wanted to remind you that in addition to the Lynch Syndrome Educational Workshop, we also have the Lynch Syndrome Patient Advocacy Network, or LSPAN, which is really a support group for patients with Lynch syndrome. It's sort of an open and safe space to talk about unique challenges and emotional aspects of living with Lynch syndrome. This meeting is usually hosted by a social worker and a genetic counselor. We'll let you know when the next one will be. We usually skip the April, March because we have this educational workshop, and an invite will be sent to all of you who are here today if you know your email address. Reminders about the workshop and just about sort of housekeeping stuff, please post your questions in the Q&A box and we'll be able to see these, and we will try to answer as many as we possibly can during the moderated Q&A session. You will receive a few days after the workshop an anonymous survey, and we really value your feedback. So tell us what you want to hear about, what you want more of, what you want less of. We take these very seriously. We reviewed them after the webinar, and we base our next year's speaker invitations based on your feedback. And a recording will be made available publicly on the MSK website in the coming weeks. I would like to say coming weeks, but usually it takes us a little bit longer. So give us at least a month for it to be posted on MSK's website. And then for any specific clinical genetics questions that are very personal, probably not the best in the Q&A, but you can always reach out to us, or you can reach out to your genetic counselor if you saw us in CGS, and the number is there. Okay. This is a special thank you to someone who is behind the scenes, and you don't see her, but she's integral to the functioning of our research projects and to this workshop. She's really the main person that helps to plan this, and that's Mathilde Borio, and we're very sad but very excited for her to start her new endeavors in the experimental drug development service of MSK. So she's staying at MSK, which is wonderful, but she'll get to experience what it's like to do therapeutic trials, which we don't do as many of in genetics. She has been a terrific clinical research coordinator for the last 2 years, and we are going to miss her greatly. So congratulations, Matilda. We're very excited for this promotion for you. And we also want to thank our funders for this, the Robert and Kate Niehaus Center for Inherited Cancer Genomics, for their generous contributions, as well as the Romeo Milio Lynch Syndrome Foundation and the Fieldstone family for their continued support. So what I'll talk about first, and I'll try to go fast so that I don't take any time from anyone else, is to give you an overview on GI cancer risks and opportunities for immunointerception in Lynch syndrome. So we know that GI cancers happen at an increased frequency within the setting of Lynch. So all of us know about colorectal cancer risk in Lynch, but there are a number of other gastrointestinal tract cancers that can occur in the context of Lynch syndrome, and that's stomach cancer, or gastric cancer is the other name for it, cancer of the pancreas, cancer of the biliary duct, rare, but we do see it, and then cancer of the small intestine. And just to give you an idea, obviously here is the stomach, and then the first portion of the small intestine is right here. That's what we call the duodenum. And then the rest of the small intestine is in here, which goes into the large intestine. This is the ascending colon, transverse colon, descending colon, and ultimately the rectum. So these are some of the organs that I'm going to concentrate on today. I do have to say that obviously there are many other non-GI cancer risks in Lynch. Obviously, Dr. Liu will talk about endometrial and ovarian cancer risk. I think we previously had discussions of urothelial cancers, skin lesions, mostly sebaceous neoplasms, and then other rare cancers can also occur. But just to focus in a little bit up on these GI cancers, so obviously the most important one is colorectal cancer. And the risk of colorectal cancer really varies by the type of mutation that a patient with Lynch has, with the highest risks being in MLH1 and MSH2 mutation carriers, which are about a 50% lifetime risk of colorectal cancer compared to a population risk of probably 4 to 5% in the general population. So much, much higher risks. Even in MSH6, risks are higher than in the general population, but much lower than in MLH1 and MSH2, and probably even a lower risk, ultimately, of lifetime risk of colorectal cancer in patients with PMS2 mutations. But in addition to colorectal, there are these other 4 GI cancers. Gastric cancer we more commonly see in MLH1, but we do see it in the other mutation carriers as well. Very little data is known on PMS2 and gastric cancer risk. And the risk is again higher than the about 0.9 or 1% population risk of this cancer. Small bowel cancer. So I showed you that where the small bowel is, and it is an extremely long organ, and the main job of the small bowel is actually food absorption, because remember the colon just absorbs water, but the food is mostly the nutrients are absorbed in the small bowel. And the risk is highest actually in MSH2 carriers, with much lower risks, probably especially in MSH6 and PMS2 carriers. Pancreas is also increased. The data on PMS2 are a little bit fuzzy, probably not much data there, and some studies don't show an increase in pancreas cancer risk in PMS2 carriers, but certainly there is an increased risk, especially in patients in MLH1. We have also seen some patients with MSH2 and MSH6 mutations with pancreas cancer. Not common, but we do see an increased prevalence compared to the general population. And then biliary tract, I'll tell you that I see very little of this. It's more predominant in patients with MLH1 mutations, but I've been here for 16 years, and it's very few biliary tract cancers that I have seen. And so I won't cover the screening for that. There's really not very good screening for biliary tract cancers. So I wanted to quickly go over what the screening recommendations are for these 4 GI cancers. So colon cancer is sort of the easiest. Obviously, all patients with Lynch syndrome should undergo colorectal cancer screening, or what we call high-risk surveillance, or because we want you to do the colonoscopies more frequently. And this is with a high-quality colonoscopy. And generally in the high-risk mutation carriers like MLH1 and MSH2, both MSK and NCCN recommend starting those colonoscopies at age 20 to 25 and then repeating it every 1 to 2 years. At Memorial, we usually do these colonoscopies on an annual basis. MSH6 and PMS2, you saw that the colon cancer risk is lower. So NCCN has sort of shifted their recommendations. NCCN is sort of the National Comprehensive Cancer Network that provides guidelines on screening. and MSK is part of that NCCN network, and they recommend later age at starting colonoscopies in MS stage 6 and PMS2 carriers at age 30 to 35. We haven't adopted those recommendations at MSK, partially because our patient population is so young that we tend to screen them at age 20 to 25. Our cancer population, even for PMS2 and MS stage 6, seems to be biased towards the younger side. It's important that an adequate bowel prep be done for the colonoscopy. And even if a patient has had colon surgery, so for example, they had a colon cancer and part of their colon was removed, any residual colon still needs to be surveyed on an annual basis. So for example, in patients who had a subtotal colectomy, for example, and only the rectum remains, that rectum needs to be screened on an annual basis. And this is the only efficacious GI screening a method that's available. So the next ones that I'll talk about, we recommend, but it's really based on expert recommendation, not so much on great evidence. So the next one is stomach or gastric cancer. And for these patients, current guidelines recommend that all Lynch patients undergo upper endoscopy at certain frequencies. Generally, we say to do the upper endoscopies roughly every three years. I think in our recommendation, we put every 2 to 4 years, and that's what NCCN says as well. We start around age 35 to 40. I think NCCN says age 30 to 40. We have sort of said that age 35 is generally enough unless there's a strong family history of gastric cancer. This hasn't been proven to be efficacious, but we do recommend this screening and also assessment for H. pylori, which is a bacteria that can cause inflammation in the stomach and can actually lead to higher risks of abnormal gastric mucosa and even gastric cancer. So moving on to the next one will be small bowel. In patients, even within the context of Lynch, small bowel cancer is very, very rare. However, if you take all small bowel cancers, about 10% of small bowel cancer patients are positive for Lynch syndrome, which is a really high percentage. We consider surveillance of the small bowel in very select individuals and families, and it's mostly those with a strong family history of small bowel cancers who tend to be, as I mentioned before, MSH2 carriers. And in these patients, the methods of screening for the small bowel are somewhat limited. You can do an upper endoscopy or with a push enteroscopy, which can visualize further into at least the beginning parts of the small bowel. But really what we utilize is CT scans or MRI enterographies, which take very nice close pictures of the small bowel and can help to pick up small polyps or lesions, which I'll show you on the next slide. Or capsule endoscopy, and here's the little picture of what this video looks like. It's essentially capsule endoscopy is a little video that you swallow, and then it takes pictures throughout your small bowel and can identify any kind of polyps or abnormalities in the small bowel. For patients with a strong family history of this, where we recommend the screening, we usually start at around age 35 to 40, and we repeat it roughly every 2 to 4 years. Obviously, if there's a finding, we may repeat it more often. But this is something that, again, is reserved for a small fraction of the population. I should also say that capsule endoscopy, we really only do in the surgically naive abdomen. That means in a patient who has not had bowel surgery or any kind of abdominal surgery, because in those patients, you can have adhesions, and we don't want this little camera to get stuck, because then we would have to go in surgically and take it out, which is not something that any patient would want. So what does the MR enterography look like? This is courtesy of Dr. Mark Golub, who actually reads these images. He's a radiologist. So this is an MR enterography, and you can see that here in the small bowel is a lesion, is a polyp. A couple of other pictures. This is actually not in the small bowel, but in the large bowel, there is a lesion. An MRI, very nicely visualized. And then in looking at it from this angle, you can see that there's a lesion here, and there are also lesions here. This is small bowel, this is large bowel. So this is what we sort of see on MR enterography, and these can detect these polyps in the small bowel that unfortunately we are unable to scope with colonoscopy, and we also can't get to it with an upper endoscopy. So pancreatic cancer, nowadays all patients with a pancreatic cancer diagnosis are recommended to undergo germline genetic testing, and about 4 to 10% harbor a germline mutation, but the most common mutation is actually not Lynch, it's BRCA2. In Lynch, probably accounts for only about 1% of pancreas cancer. So again, very, very rare. We consider surveillance of the pancreas in Lynch patients who have a family history, either in a first or a second degree relative with pancreas cancer. And in those patients, we do usually recommend annual MRIs or MRCPs of the pancreas, which gives us very pretty pictures of the pancreas to look for any kind of abnormalities. Some institutions do endoscopic ultrasound, which is an upper endoscopy, and then an ultrasound probe is put onto the backside of the stomach to look at the pancreas very carefully. We tend to go with the MRIs of the pancreas for screening and usually refer our high-risk patients to Dr. Vineet Ralston, who again gave an entire talk on this topic before. We don't start this before age 50 generally, unless there's a very strong family history of early onset pancreas cancer. And after age 50, again, we repeat it on an annual basis. We do have some major potential limitations, including high incidence of benign findings in the pancreas. And the benefit of pancreatic cancer screening has not been proven yet. We also worry a little bit about cost. Sometimes these are hard to get covered by insurance, although I don't think we have had much trouble as long as there is a mutation and a family history of pancreas cancer. So those are the surveillances that we do. And then what I wanted to switch to now is sort of talk a little bit about what we do for the treatment of these cancers. So we know that most of the Lynch syndrome associated cancers are mismatch repair deficient or are microsatellite unstable, which is just two ways of sort of saying the same thing. These tumors create a lot of mutations, specifically what are called neoantigens. And for rectal cancer, if we specifically look at it, only about 5 to 10% are mismatch repair deficient. But we did a study back in 2020 where we looked at response of these mismatch repair deficient cancers, many of whom have Lynch syndrome, to chemotherapy. And what we realized is that these patients are actually less sensitive to FOLFOX, which is the traditional chemotherapy given upfront to rectal cancer patients. In fact, you can see that about 29% of the patients progressed on chemotherapy with mismatch repair deficient or Lynch-associated rectal cancer, while none of the non-Lynch rectal cancers progressed, suggesting that chemotherapy doesn't work so well in this setting. And by that time, we already had data suggesting that mismatch repair deficient colorectal cancers in the metastatic setting were highly sensitive to immunotherapy. So this brought up this whole idea of, well, what can we do with immunotherapy? And so just a few words on immunotherapy, and I think Dr. Lume mentioned this as well in her talk. What is immunotherapy? So the most common types that you hear about are PD-L1 and PD-1 inhibitors and CTLA-4 inhibitors. And what happens in a Lynch cell, in a Lynch cancer cell, I should say, is that the Lynch cancer cells makes many, many mutations, which can be converted to these neoantigens that are actually present near the tumor cell and in the bloodstream. And these dendritic cells can take up these neoantigens, and they can express them or show them to the T cell. So the T cell is a type of white blood cell that helps to keep our immune system in check, but it can also be triggered or have an immune response to start to attack things that are foreign. And so when this neoantigen is exhibited by the dendritic cell to the T cell, then the T cell should get very, very excited to start to fight off any kind of cell that's producing these neoantigens. But the cancer cell is pretty smart, and what it does is it tries to sort of switch this triggering off. And what it does is the PD-1 receptor that's expressed on the T cell binds to the PD-L1 receptor, which is often overexpressed on the cancer cell. And that's basically like an off switch for the T cell. So then the T cell doesn't get excited. So what these immune checkpoint inhibitors do is they basically inhibit this binding of the PD-L1 and the PD-1, and therefore they allow this dendritic cell to excite this T cell, and then the T cell goes and attacks the cancer cell. So that's the basic premise behind immunotherapy. Essentially, you're making your immune system work better for you. And so there's been a lot of excitement in terms of using immunotherapy before cancer surgery. So if you pay attention to the bottom screen, I'm actually going to talk about that one first. This is a really nice article, a review article in Nature Medicine that demonstrates why we think that neoadjuvant or upfront immunotherapy may be helpful in these patients. So here is the tumor, and then you give it the immunotherapy. That's the immunotherapy here. And the immunotherapy triggers all these T cells to come into the tumor and to recognize the tumor as being essentially foreign or bad. Then the surgeon, after immunotherapy, goes in and takes out the tumor if it needs to be taken out. And then you're left with a ton of these activated T cells that can continue to fight off any kind of tumor cells should they resurface in the body. So wherever they may pop up, the T cells are there to take care of it. That's kind of the premise behind upfront immunotherapy prior to surgery. What happens if you have the immunotherapy after surgery? So what we worry about, but this is a little bit theoretical because certainly immunotherapy works in some cancers after surgery, is that if you take out the tumor first, so the surgeon goes in and takes it out, and then you give immunotherapy, you may get some triggering of some leftover cells potentially. So you will have some T cell response, but your T cell response won't be as robust as the T cell response if the immunotherapy was given prior to the tumor being introduced. And so this was the sort of the premise of the rectal cancer study that Andrea Sursak ran here that was published in the New England Journal of Medicine 2 years ago now, I think, where she gave a PD-1 inhibitor, dostarlimab, to patients with mismatch repair deficient locally advanced rectal cancer. After the immunotherapy, if there was leftover disease, then these patients would have gone on to chemoradiation and sort of standard treatment and chemotherapy. If, however, they had a complete response, then that means that no tumor is seen on endoscopic evaluation or on any imaging, then we would not do surgery on these patients. And so what was seen, and this is sort of updated data since the initial few patients, I think 16 patients that were demonstrated in the New England Journal study, was that after about 6 months of the dostarlimab, all of these patients, you can see the yellow dot here, had a complete clinical response. So therefore, they did not require surgery of their rectal cancers because the rectal cancer essentially melted away to the immunotherapy. And I think she has over 48 patients now who have rectal cancer have received this treatment, but this was a really fantastic response, but the possibility of avoiding surgery. These are just some examples. You can see that the endoscopy of this is what we call a fungating rectal tumor, also very PET avid right here. And you can see the really nice response endoscopically. This is on sigmoidoscopy, and then also on imaging that the tumor just basically goes away. We are expanding this trial not to just rectal cancer, but to essentially patients with solid tumors with mismatch repair deficiency, with the endpoint really looking at a non-operative approach. Can we treat some patients with mismatch repair deficient or Lynch-associated cancers with dostarlimab and actually avoid undergoing surgery? And the results of this are currently under review, but we're obviously very excited to see this. So what are the long-term implications of immunotherapy in Lynch? So we have had so much success with this, but one of the questions that we wanted to ask is, if a patient has gotten immunotherapy with Lynch syndrome, do we actually alter their chance of a brand new malignancy? So we looked at this question of whether immunotherapy that one receives actually alters their risk of a new cancer or a new pre-cancer. And this was with a collaboration with Emily Harold, who's a fellow who was here with us from Ireland, and Dr. Diaz's laboratory. And what we found is indeed actually after immunotherapy, patients still got new cancers. So Lynch patients, 12% of them developed a new subsequent malignancy. And with about 91% of these tumors actually still being mismatch repair deficient. So they were clearly Lynch tumors. So the immunotherapy did not seem to prevent all tumors, and patients also got precancerous adenomas in the colon on colonoscopy surveillance after immunotherapy. When we compared what the frequency of cancer was prior to immunotherapy versus after immunotherapy in the overall cohort, we didn't find a significant difference. But when we actually broke this down into patients who developed visceral lesions, that's like internal cancer. So cancers of internal organs, which are the ones that are potentially fatal. What we found is that actually immunotherapy seemed to decrease the risk of these internal or visceral cancers. But there seemed to be a little bit of an increase in the skin lesions, specifically sebaceous neoplasms that I mentioned before after immunotherapy, suggesting that dermatological screening in these patients is very, very important. Whether this is a lasting benefit, we still need to demonstrate, but we were pretty excited to see that maybe there's a little bit of a benefit on risk of internal malignancies in patients who have received immunotherapy with Lynch syndrome. So in conclusion, GI cancers other than colorectal cancer can happen in Lynch, but unfortunately we only have one efficacious screening for GI cancers, and that's colonoscopy. But by expert panels, we do recommend a variety of other screening methodologies, some of which are based on family history and the type of mutation that may be present in the family. Immunotherapy is starting to play a very big role in the treatment of Lynch-associated cancers, not just in the advanced stage or stage 4 disease, but also in early stage disease and with a non-surgical approach, where we give immunotherapy with the goal of making the tumor completely go away so that the patient doesn't need surgery, really kind of revolutionizing the treatment of these cancers. Immunotherapy does not eliminate the risk of new cancers or new precancerous adenomas. So surveillance with the techniques that I mentioned is very important after immunotherapy. And I would say dermatological surveillance, again, is also very important. We are now asking the question of whether there are certain types of immunotherapy that can better prevent this in the long term, and could we do trials to actually prevent Lynch-associated cancers with immunotherapy. So I want to thank all of our collaborators. We have a terrific set of attendings, nurse practitioners, and genetic counselors on the clinical genetics service. I already made a shout out to Matilde Borio, who has been wonderful, and all of our other collaborators. Then we published this study on immunotherapy in Nature Medicine. They were kind enough to select our drawing by Samantha Velker at MSK in MSK Graphics for their front cover. So we're pretty proud that Lynch syndrome made the cover of this Nature Medicine magazine. And that is actually the end of my slides. I'm going to stop sharing. All right. And it's my pleasure to now introduce Dr. Latham. And Dr. Latham is one of our attendings on the clinical genetics service, and is also the medical director of the MSK Catch Clinic, which she'll talk about. It's our high-risk surveillance clinic that she organizes. And she'll talk about updates in Lynch syndrome research over the last year or so, and some of the really nice work that she has been conducting. So Alicia, take it away.
Thank you. Let me just share my screen. All right, so as Dr. Sadler mentioned, I want to give you some updates, both in some of the studies that we're working on here at MSK, but also some recently published work that has been at other institutions as well, that I think you'll find interesting, mainly because many people ask me about this in clinic. So if you remember, Lynch syndrome, it's what we call an autosomal dominant condition. So what that means is that it only takes one non-working copy of the mutated gene to manifest the syndrome. And it also means that there's a 50% chance of passing this mutated copy on to the next generation. So as you can see in my little picture here, so we're going to say these are my representations, my little cartoons of genes here. So let's just say that this is a mother who has a mutation on one of her copies of one of her MLH1 genes, for example. And this is a father who does not have a mutation. He has two what we call normal copies of MLH1. If they have a child, then the father will pass on a normal copy, but the mother could pass on either a normal copy or a mutated copy. So that's autosomal dominant. And particularly in Lynch syndrome, as you've heard from Dr. Stadler, and you've heard many times before, it's caused by mutations in the mismatch repair genes, which are listed here. So what is the mismatch repair system? So I like to think of this as the body spell checker, and that's why I put our little friend Clippy here to remind me of what I say. And if you see me in clinic, then you've heard me say this before. What this system does is When you think about cancer in its simplest form, it's really kind of an accumulation of mutations that go unchecked. And we have multiple systems in our body in place to correct errors that may happen that lead to those mutations. This is one of those systems. And the way that it does this is that these genes, as part of the system, pair up together and they start reading the DNA that may have had an accidental mutation or insertion or something to that degree occur whenever that DNA was being replicated. And the mismatch repair system is there to fix the mismatch. It's to correct that strand. And so Lynch syndrome is what happens when you have a germline or heritable mutation in one of those genes. And this leads to an accumulation of mutations that, if gone continually unchecked, can turn into cancer. And interestingly, this does seem to occur at higher frequencies in something called microsatellites. Now, you heard Dr. Stadler talk about microsatellite instability, and you've heard a lot of data around treatments that work in microsatellite unstable cancers. But just to kind of give you a little bit of additional information, what microsatellites really are, when you hear that term, are they're these little repeat sequences throughout our DNA, and I like to call them the bookmarks. And basically, the mismatch repair system is hunting for those little bookmarks. When it finds them, it starts reading the DNA. If it sees an error, it's going to fix it to correct that mismatch. If it doesn't work correctly, those microsatellites, the length of them can change over time. So maybe they start getting longer or shorter. And so when you're looking at a now cancerous cell, those microsatellites have unstable links throughout them when compared to a normal cell. And that is microsatellite instability. And that is why people with Lynch syndrome, the cancer is Lynch associated, has that microsatellite unstable signature. And we've actually demonstrated now, gosh, I can't believe it, Dr. Stadler, 5 years ago, that this was a signal that was seen pan-cancer. So historically, when we were thinking about Lynch syndrome and an MSI signature, people really thought about this for our classic, or what we call canonical tumor types, colorectal and endometrial cancer. And it's been done for many, many years that those cancers are screened for microsatellite instability or mismatch repair deficiency as a screening test for Lynch syndrome. And so this study was really demonstrating, when we looked at over 15,000 tumors and looked at their MSI status in those tumors, that about 50% of the time, these MSI high cancers and underlying Lynch syndrome were found in tumors that were not colorectal or endometrial. So it's really important to highlight because we now know that this was a pan-cancer syndrome. In terms of what that means for vaccines, it means that Lynch syndrome is ideal for vaccine development. So that's why I'm segueing into this now. So as Dr. Stadler mentioned in her talk, when you're thinking of immunotherapy, these mutations are really looked at and recognized by the body as foreign. So here you have your normal strand, kind of what I was talking about, where a mismatch occurs in this normal cell and an intact mismatch repair system would repair that. In a now cancerous cell, if that doesn't work over time, the cell can become cancerous. And now you see that this is not repaired by that complex. And this results in what's called a frame shift, which is again kind of stretching out that length. This is now looked at as a mutated protein, or a word that you've heard just a moment ago, a neoantigen. So the body kind of recognizes that as foreign, and the immune system is now targeted to try to go and attack that foreign invader, if you will. And so this was a really nice graphic that was put together in a review, just as the previous one, looking at why vaccine development is so interesting and why Lynch syndrome is ideal for this. So this is very similar to the graphic that Dr. Stadler showed you, in that, you know, this neoantigen here, which is basically these mutations that have accumulated, it's then taken up by this thing called a proteasome. And that word's not important. Just think about it as a vehicle. And really the purpose of this is to break down something into peptides so that they can be then tagged by this little complex here, so that they can be tagged to say, oh, here's my flag. This is foreign. I'm tagging it for my T cell. And that's exactly what this is going and doing in this process that both immunotherapy and now vaccines are now trying to harness. And this has been successful in mice. So this was a study that was published in 2021 in gastroenterology, where they were looking at a mouse model And they were trying to select the most informative neoantigens here and making a model to see, could you elicit an immune response in mice, and then therefore later challenge them if you were to have a mouse that developed cancer, you get cancer cells too, could you then induce a vaccine response? And all of these are really just kind of showing similar ideas in that anytime they had a combination of something with their vaccine trial, whether it be aspirin or a different type of anti-inflammatory medication, as long as it had that vaccine, you did see an induction of that response. You saw that a mouse that received that had a lower tumor burden. They also had prolonged survival. So this was one of the first studies that really looked at, okay, is this something that we should be exploring for humans? And they are. So there are clinical trials underway for patients with Lynch syndrome. I just checked this again today. This is still recruiting. So this is one of those trials, cancer prevention vaccine. It's called News 209 for patients with Lynch syndrome. If you're interested in looking at this, this is the clinical trial ID. The key eligibility criteria for this are that patients must be over 18 years old. They have to be diagnosed with Lynch syndrome, and this can either be a genetic diagnosis, meaning a confirmed mutation, or a clinical diagnosis. If they meet very strict criteria, sometimes we have mutations that we haven't been able to find with current genetic technology, so that's why they allow for that inclusion. And they can't have active cancer within the last 6 months. The sites that are recruiting for this currently are California at City of Hope, Pennsylvania at Fox Chase, Texas, MD Anderson, and then actually a site that's recruiting now is at the University of Puerto Rico. The second trial is looking at testing a combination of vaccines for prevention in Lynch syndrome. So not just the prior one, but that one plus a couple of others, to try to see if there's some way that you can kind of mimic that mouse model in terms of a synergy, meaning an improved effect with different vaccines, or if one is enough, or if you combine them, is that going to enhance a response? So the eligibility criteria for here are very similar. One key point that they make in their clinicaltrials.gov listing is that if patients are on aspirin, they have to be willing to do an aspirin washout phase, meaning to stop aspirin for a certain amount of time before being allowed to enroll, simply because they are looking for their synergistic effects. This is recruiting at these locations, so Ohio, Massachusetts, Kansas, Illinois, Arizona, Michigan, and Texas. That's just who's currently recruiting now. This one is actually going to roll out to multiple sites in the future, but these are just the sites that are open currently. And thank you all very much for your attention, especially our funders here, and most importantly, you, our patients that make all this possible. Thanks.
Thank you so much, Dr. Latham. That was a really terrific overview, and there are some really good questions about this that we can also address during the Q&A, so keep the questions coming. So it's my pleasure to introduce Dr. Ying Liu, who is lead of our Inherited Gynecological Cancer Program and is an attending in the Clinical Genetics and GYN Medical Oncology Service. So that means she sees patients with us in clinical genetics for counseling with the genetic counselors, but she also has a medical oncology clinic where she treats patients with gynecological cancers, again, focused on inherited predispositions. So she will talk about gynecological cancer risks and treatment approaches. Thank you so much, Dr. Liu.
Thank you so much, Dr. Stadler, and it's really exciting to be here tonight. Thank you to everyone who's joining us. These are my disclosures. And so tonight I really wanted to go over what are the characteristics of the GYN cancers that we see with Lynch syndrome, and talk about what the risks are for developing these by gene, and talk about different ways that we can prevent them. And then in the last few minutes, I'll kind of go over some new exciting data about novel treatments in endometrial cancer. Alrighty, so just a little bit of anatomy, just to orient all of us. So we know that Lynch syndrome is associated with increased risk of endometrial cancer and special types of ovarian cancer that are generally related to endometriosis. So I'm bringing up this picture of the female uterus just to kind of orient ourselves. So I always tell my patients, think of the uterus as an upside down water bottle. Babies, grow from the inside, they come out through the cap, that's the cervix. It's the same with cancers. They grow on the inside in that endometrial lining, and they also can grow outside of the bottle. They can grow through that cap, and they can also spread through the lymphatic system, and that's what we're seeing here. The ovaries are kind of like eggs. And in general, the most common type of ovarian cancer are the ones that actually arise from the outside of the ovary, kind of where they interact with the fallopian tubes. But this is not typically the type of cancer of ovarian cancer that we see with Lynch syndrome. We actually see more of types of cancers that are related to endometriosis or endometrial tissue that it's in places that it's not supposed to be. So kind of just keep that in mind. Now, what are the symptoms of endometrial and ovarian cancer? The most common symptom of endometrial cancer is abnormal uterine bleeding. Now, what does that mean? So in a premenopausal woman, that means sort of abnormal atypical bleeding in between periods. In a postmenopausal woman who's not having any more periods, it's any bleeding at all. Other symptoms that one could have would be pelvic pain, difficulties with urination, pain with intercourse, or changes in your bowel habits. Now, the symptoms of ovarian cancer are even more nonspecific. They can be things like bloating, swelling, ascites, which is fluid in the abdomen, pelvic pain, feeling full, changes in your bowel habits, changes in menstrual bleeding, back pain, weight gain, or weight loss. So very nonspecific symptoms. So what are the actual lifetime risks of developing both endometrial and ovarian cancer in Lynch syndrome? I think we're starting to understand these risks more by the different genes, and we're starting to see that the different genes confer different levels of risk. So I kind of like to think about it in groups. So for endometrial cancer, I lump MLH1, MSH2, EpCAM, and MSH6 together because the lifetime risk of endometrial cancer is still pretty high, upwards of 40 to 50%. The average age of diagnosis is kind of in your late 40s, early 50s. In PMS2, you see that the rate, the lifetime risk is slightly lower, but it's still higher than the average, woman's risk, or what we call the population level lifetime risk, which is about 3 to 4%. And when we're looking at ovarian cancer, the difference between the genes is even more stark. So here I lump MLH1, MSH2, and EpCAM together. And the risk here, the lifetime risk of ovarian cancer can range anywhere from the 20 to 30%. Average age of diagnosis is kind of in the mid to late 40s. And that's significantly higher than the population level risk, which is about 1 to 2%. With MSH6, it's a little bit lower, but it's still higher than 1 to 2%. And the newer studies kind of put it more in the 10 to 15% lifetime risk range. And then PMS2 is where it's a little controversial. Some of the studies of PMS2 show that the risk is much lower and may really not be that much higher than the average woman. So there's big differences here by the different genes. Now, how do we manage risks of these cancers? Are there screening options? Unfortunately, for ovarian cancer, we do not currently have good screening options. We don't have anything that's really been proven to save lives. In fact, the FDA actually issued a safety warning back in 2016 because the screening was so ineffective that it was preventing women from doing the intervention that was effective by giving them kind of false reassurance. And in ovarian cancer, the gold standard is still risk-reducing surgery to prevent ovarian cancer. For endometrial cancer, there's no proven survival benefit to screening, but there are things that you can consider. You can consider endometrial biopsy or transvaginal ultrasounds in postmenopausal women. It's less reliable in premenopausal women. And the role of tumor markers like CA-125 is really unclear in endometrial cancer and in ovarian cancer. And these pictures here kind of depict what a transvaginal ultrasound and what endometrial biopsies look like. But the gold standard really for preventing these cancers is still surgery. And so what does this surgery consist of? Well, there's a couple different parts. So the hysterectomy is the removal of the uterus, and that's usually done laparoscopically, by expert GYN surgeons. And then you have the fallopian tubes here, which really are kind of conduits for eggs. They don't secrete any hormones. And then you have the ovaries, which have your oocytes or your eggs and also secrete hormones. And so removal of the ovaries is called a salpingo oophorectomy. That's removal of the ovaries and tubes. And if we do both, we call that bilateral, both sides. Now, we've talked a little bit about symptoms. We've talked a little bit about surgery for reducing the risk of endometrial and other GYN cancers. What are some other things that we can do? Are there medicines that we can take? And there are. So, we talk a lot about aspirin and reducing cancer risk in Lynch syndrome. The strongest evidence is for colorectal cancer, but there may be some effect for endometrial cancer. There are data to suggest that oral contraceptives and even the Mirena IUD can reduce the risk of both endometrial and ovarian cancer. You have to balance that with sort of the risks of taking those. And then there's, really interesting data kind of looking at your metabolic status. And so things like keeping a healthy body weight, exercise, avoiding smoking and alcohol are all good things. And there's a lot of interest in looking at medicines like metformin and other drugs that potentially influence the insulin pathway, because that's very important in endometrial cancer. All right, so going kind of into the nitty gritty. So what are our recommendations for reducing the risk of GYN cancers in Lynch syndrome? So these are kind of taken from the NCCN, and I'm just going to go over kind of the highlights and try to put into context for everybody, because it's a lot of words. In general, the move has been to make recommendations specific to each gene, and I like to talk about MLH1 and MSH2 and EpCAM together. In general, to reduce the risk of endometrial cancer, hysterectomy is recommended. The timing of this is individualized, and I'm going to talk a little bit more about that. But for women who are not ready for hysterectomy yet, endometrial biopsy every 1 to 2 years, starting ages 30 to 35 is reasonable. If you're a postmenopausal woman who hasn't had a hysterectomy yet, a transvaginal ultrasound could also be considered. For ovarian cancer, again, the recommendation is for bilateral salpingo oophorectomy, or BSO. And again, the timing of this should be individualized. If this happens in the premenopausal setting and in young women, then definitely we should consider estrogen replacement. And I know Lisa's going to talk a lot more about this. And then again, the emphasis is that there's no effective screening, and you could consider risk-reducing agents. All right, so it gets a little bit more controversial when we start talking about MSH6 and PMS2. So for MSH6, the recommendations for reducing the risk of endometrial cancer are very similar, because the lifetime cumulative risk is still pretty high. Again, hysterectomy is recommended. Timing we'll talk about in a little bit. Before that, endometrial biopsy could be considered. With ovarian cancer, because the risk is slightly less, the language is a little bit more flexible. There's not, there's insufficient evidence to make strong recommendations, but we can still consider BSO. That's generally what we do counsel patients on, and we sort of talk about timing. And if that's done in premenopausal women, then definitely would consider estrogen replacement. In PMS2, the risks of both endometrial cancer and ovarian cancer are less, and they tend to happen a little bit later. So that's where the recommendations vary a bit. And so again, hysterectomy can still be considered, but the timing of that might be a little bit later. Endometrial biopsy is still useful here. For ovarian cancer risk, the evidence is really, there's very little evidence. And there might be only a very mildly increased risk of ovarian cancer, or even no greater than average risk for ovarian cancer. So you could potentially defer BSO or wait until the postmenopausal setting. And here we do a lot of individualized counseling, and we talk a lot about family history. So how do we decide, or how does someone decide when to do these surgeries, and do you do them all at the same time? Do you do the hysterectomy with the tubes in the ovaries, or do you do the hysterectomy with the tubes first and then the ovaries later? These are all very tough decisions, and this is a lot of what we spend time talking about in clinic. And sometimes I help our women make these decisions by kind of showing them the best data that we have. And so these are data adapted from a really large cohort of patients with Lynch syndrome out of Europe. And I took actually the tables and I plotted them for this, because I think it's a little bit easier to see. And what we have here is we have age on the x-axis going this way. And then we have cumulative lifetime risk, or cumulative incidence of endometrial cancer. And as you can see, as time goes on, as we get older, that risk increases, but it's different for the different genes. And so you see for MSH2, MSH2, MSH6, and MLH1, that risk goes pretty high, and it actually starts increasing, in your late 30s, early 40s, whereas in PMS2, it's a little bit later and the risk isn't as high. And I plotted here in orange the population level risk, kind of to give you an idea. And so this is helpful for women who are trying to make the decision about, well, when should I have a hysterectomy? I did the same thing here for ovarian cancer risk. So again, this is age on the x-axis, cumulative incidence of ovarian cancer on the y. And you can see here that MSH2 and MLH1 kind of track together with their risk. And you can see when that risk starts to really increase. And again, you have the population level risk here in orange. I didn't plot the error bars for MSH6 and PMS2 because they're quite wide. So you have to keep that in mind. But the risks definitely seem to be lower. And for PMS2, it really is closer to population level risk. So we often use tools like this to help our patients make the decisions that are, the right thing for them. Now, the caveat being, this is one study out of Europe. It is certainly the largest study, but there is variation. And, this is a study that we did internally looking at our patients with Lynch syndrome related to MSH6 and PMS2, and we still found pretty, high rates of ovarian cancer, even in PMS2 and even at young ages. So it's not to say that it doesn't happen, and it's just we need more data. Alrighty, I'm going to switch gears a little bit and talk more about advances in endometrial cancer treatment. So endometrial cancer is unfortunately one of those cancers where the incidence is actually rising. Even though we're getting better at preventing other cancers, this is one that is rising. And we think a lot of it is related to rising obesity because we're seeing very high rates and higher growth in our high income countries in areas like the US. However, we are also seeing increasing rates in low and middle income countries as well, and that's shown here in this figure. I think the biggest breakthrough recently in endometrial cancer is our appreciation that it's not just what's under the microscope, not just, the pathological or histological type of endometrial cancer that matters, but actually the molecular signature. And you can see here that there's 4 main types of endometrial cancer when you look at it from a molecular standpoint. And the group that we're really interested in is this mismatch repair deficient or MSI high group. And Dr. Stadler mentioned this earlier. This makes up about a quarter of all endometrial cancers. And anytime we see one of these, we have a very fancy algorithm where we do lots of very sophisticated testing to try to make sure we don't miss any patients that have Lynch syndrome, because a good portion of these, or a small portion of these patients will have Lynch syndrome. And in general, we see about 3% of patients diagnosed with endometrial cancer having Lynch syndrome. Now, Dr. Stadler had a much better figure and already gave a really good explanation of how immune checkpoint inhibitors or immune therapy works. And it's particularly effective, like she said, in tumors related to Lynch syndrome because the mismatch repair pathway is so important to fixing our DNA. And when it's broken, you have a lot of mistakes, which generate antigens, which can help generate a more robust immune response. And I think the biggest thing that we've seen in endometrial cancer recently is that now we've shown that adding immune checkpoint inhibitors like dostarlimab and like pembrolizumab to standard chemotherapy has really helped women with these mismatch repair deficient and MSI high endometrial cancers live longer and be in remission longer. So, these are Kaplan-Meier survival curves, which we love in oncology. But I think the main thing I just want to point out is that, the yellow group is the one that got the immune therapy and the blue group is the one that didn't. And, if you're the higher up, the closer you are to 100%, the better. And you can see, clear difference and clear benefit here. And so it's great that now both of these agents are available for treatment. And that's really, changed a lot of our treatment for endometrial cancer. A couple of sort of interesting notes. Well, only a portion of mismatch repair deficient endometrial cancers are related to Lynch syndrome. And are they different than the ones that are related to changes that happen only within the tumor? So we actually looked at this in a small series from MSK, and Dr. Manning Geist was the fellow that led this. And we looked at mismatch repair deficient endometrial cancers associated with Lynch syndrome, associated with changes just in the tumor, or associated with methylation changes. And we found that the tumors related to Lynch Lynch syndrome had higher mutational burden, meaning more of those changes or mistakes or neoantigens and more immune cells in the tumor. And so we're hypothesizing that maybe they would have an even better response to immune therapies. And sort of speaking of ways to make the response to immune therapy better, there's a lot of trials looking at novel combinations. I know Dr. Stadler talked a lot about this in GI cancers. Dr. Latham talked about vaccines. One thing I want to bring up is radiation. Radiation is another therapy that we often use in endometrial cancer, and radiation damages DNA. So could combining radiation with immunotherapy lead to a better immune response? And certainly we hypothesize that it might, that adding the radiation creates even more of these neoantigens, leading to a better immune response when you add immune therapy rather than just the immunotherapy on its own. So to kind of test this, we have a study that I'm leading that is looking at patients with advanced mismatch repair deficient endometrial cancers and combining immunotherapy with dostarlimab as well as radiation. And we actually have fully accrued the first cohort looking at pelvic radiation, which is 5 to 6 weeks of daily radiation. And that's very tough. And I think there's a move in general to kind of shrink that radiation period into something called hypofractionated radiation. So giving slightly larger doses, but for less time. And so we're going to be opening a new cohort soon where we're going to be giving the dostarlimab still, but doing hypofractionated radiation. So instead of 5 to 6 weeks, just 5 treatments, kind of sandwich style in the middle of the immunotherapy. So please keep the study in mind. It's going to be opening soon to this new hypofractionated cohort. And then finally, I just wanted to briefly talk about the fact that endometrial cancer is one of our cancers where we're seeing not only increasing rates, but increasing disparities. And we're seeing that our non-white patients, specifically our Black patients, are being diagnosed with, more advanced cancer, more aggressive cancers, and more likely to die from their cancers. And there's a lot of reasons for this. And it's really important not just to look at the biology of the tumors, but also the environment and social determinants of health. But one of our questions was, well, are rates of Lynch syndrome different in different populations? And so we, looked at our patients with endometrial cancer who had undergone genetic testing in our service. And we found overall that we had in between 2 to 3% of patients with Lynch syndrome, and that's consistent with other studies. But we found variation by both self-reported race and ethnicity and sort of a genetic marker of ancestry, which we were able to infer from the genetic testing. And we saw the lowest rates in patients identifying as Black and of African ancestry, and we saw very high rates in our Asian populations. And we were sort of wondering, well, is there some bias here that's showing this? And in fact, there was. And the bias was actually that in our Black patients, we had less mismatch repair deficient tumors. And since that's the type of endometrial cancer that's associated with Lynch syndrome, it made sense that we saw lower rates. And so we adjusted for that. And when you adjust for that, so we're looking now at the proportion of mismatch repair deficient or MSI high tumors related to Lynch syndrome, that kind of normalizes a little bit, but you're still seeing very high rates in our Asian population. So there may be some variation or there may be some bias in which patients are being seen at MSK, but this is something interesting that we're going to look further into. We're also looking, at biological differences within the tumors of Black compared to white patients. And it's been reported before that you see more aggressive, histological subtypes in Black patients. And we're also seeing more aggressive molecular subtypes, less of the MSI high subtype in self-identified Black patients. And this is really important, not only for prognosis and staging, but also for treatment because of what I just showed you about the new approvals for immunotherapy in mismatch repair deficient endometrial cancer. And we did find that the tumors of our Black patients had less what we call actionable changes, meaning changes that make them eligible for certain therapies. And so that was really important. And it also sort of helps us know where we need to target our new clinical trials and our new therapies. So thank you all for your time. Thank you for listening. I wanted to thank our, awesome GYN and genetic services, and of course, all our patients. Thanks so much.
Thank you so much, Dr. Liu, for that wonderful overview. Really, really nice research updates as well. Okay, good. Let me introduce you. So it's my pleasure to introduce the chief of our integrative medicine service, Dr. Mao, and he's going to be talking about the role of integrative medicine in cancer prevention and treatment. And we are really looking forward to your talk. There are so many questions from our Lynch syndrome community about integrative medicine and how to incorporate it into their life that we really look forward to this. Thank you.
So, first of all, I want to really thank Dr. Statler for inviting me to this workshop. This is my first time talking about this topic to this audience, so I will look forward to questions and so I can make sure we can provide useful information for you or your loved ones to help improve your health and well-being. So, whether you are diagnosed with Lynch syndrome or you're diagnosed with cancer, right? Often the question patient would ask the doctor is, are there anything I can do? Right? At this juncture, there are a lot of needs, a lot of questions like the symptoms you're experiencing, what nutritions will function. And then there are also a lot of patients have desire to do things natural. Like a lot of my patients would say, Doc, I've never taken a Tylenol. Like I'm a herb person. I believe herb is very helpful for my healing journey. Now you're talking about surgery, chemotherapy. It's scary, right? Another thing is control. Nobody wanted to be diagnosed with cancer. Nobody even wanted to be at risk for cancer. But when sometimes you're confronted with those medical information, there's a great deal of sense of loss of control. So patients want to do something on their own. And also, you often read and hear about various sort of claims about medical benefit. Also, many patients come from different cultures, right? Like I come from Chinese culture. In our culture, there are a lot of things we believe is helpful from history, from cultural use. And the last but not least, a lot of our family and friends are trying to be very helpful, right? They try to point you toward ways to improve your health, to prevent cancer, to cure cancer, prevent recurrence. So therefore, there is a tremendous amount of use of what we call complementary and alternative medicine. In national studies I've done, 6 out of 10 patients diagnosed with cancer use a type of complementary alternative medicine, and 4 out of 10 use in the last 12 months. And 25 years ago, MSK established the very first integrated medicine service in a comprehensive cancer center anywhere, sort of outside of Asia, like China or Japan, right? So it was with a generous gift from Mr. Lawrence Rockefeller, and Dr. Barry Caslett was the founding chief. So I had the honor to take this role since 2015. So today I'm going to share with you something about our program, what kind of things we do, service we have, potentially can be helpful for you as you try to live a healthy life to prevent cancer, as well as to cope with cancer diagnosis if you have already been diagnosed. So in the last 25 years, we not only served many patients, we also created this really exciting field called integrative oncology. So here's a definition. Integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and or lifestyle modifications from different traditions along conventional cancer treatments. Our goal is to optimize health, quality of life, and clinical outcome across the cancer continuum, empower the people to prevent cancer and become active participants before and during and beyond cancer treatment. So what exactly we do? So when the patient sees us, we really try to understand the patient as a whole, trying to understand what kind of foundational lifestyle factors such as nutrition, diet, physical activity, exercise, sleep, hygiene, and stress management. So those are really important fundamental lifestyles, not only important for overall global health, but also very important for cancer prevention. For example, I was, it's great to hear some cutting edge talk from Dr. Sadler, Latham, and Dr. Ying Liu, who are experts in this disease. But some of the cancers Lynch syndrome are associated, such as, endometrial or colorectal cancer or breast, there is also a known risk factor if you're physically inactive. There's about 10 to 15% increased risk for that. So in addition to some of the chemo prevention or surgery to prevent cancer risk, so lifestyle could potentially play a role for you to do to help to control sort of the potential outcome. And also a lot of patients have a lot of questions about herbs and supplements. There's a lot of sort of marketing, a lot of myths about the use. And frankly, physicians are not often taught in medical school. We're not necessarily equipped to answer those. So we also develop resources to help patients to make informed decision whether about preventing cancer. If you're going through chemotherapy or surgery or radiation, when it's safe to use certain things, when it's not safe, when it's potentially can be helpful. Last but not least, with the research from our group as well as others, we now have demonstrated there are a lot of sort of mind-body practices or therapies such as acupuncture, massage, and yoga or Tai Chi can potentially really help address some of the common symptoms related to cancer treatment, or some symptoms I'm actually very curious to hear, because Ms. Millie's talk on hot flash, because we actually see quite a bit of hot flash women with breast cancer with hot flash using acupuncture with pretty good results. So again, when we're talking about symptom management, we are gradually really changing the way how symptom management is done in oncology. It's not just relying on medications. There are a lot of things we can engage patients to participate, to control the symptoms, to improve quality of life and well-being. So in terms of in our services, we not only have physicians and APP consultations, we also have acupuncture, massage therapy, music therapy. We're doing a really large randomized control trial on music therapy versus psychotherapy for anxiety and cancer survivors. We have finished a recruitment of 300 cancer survivors, so the results should be forthcoming later this year. And then I will also tell you a little bit our really exciting exercise and mind-body programming, and also it's research related to that. But last but not least, we have a very robust database to help patients to get reliable information about herbs and supplement. And then we do consult patients during cancer treatment to really help them navigate the complexity of herbs and chemotherapy interactions, and to make sure the herbs can be used in a safe and potentially effective way. So for example, pain is a very common symptom in cancer patients. This is one of the large randomized clinical trials we have done. We totally randomized 360 cancer survivors with chronic cancer pain, and we give them 10 weeks of acupuncture. And the orange line is usual care. Patients continue to take medications. Some of them get physical therapy. The dark gray and light grays, the dark gray is called electroacupuncture. The light gray is ear acupuncture. We show both forms of acupuncture has reduced not only pain, but also we showed improved quality of life, reduced pain medication use, and improved functions. What is really intriguing is after we finish acupuncture treatment, patients are just followed without doing anything, the pain continues to be decreased. So a lot of cancer patients ask me, like, if I benefit from acupuncture, do I have to get acupuncture for the rest of my life? The answer is not, because of acupuncture, by providing sensory input through the skin, that ultimately change how our brain perceive and process pain. So that's why I tell patients almost you unlearn the chronic pain, therefore your pain can stay low after a course of treatment. So this last year was really exciting. The Society for Integrative Oncology and the American Society for Clinical Oncology analyzed a lot of data from clinical trials on anxiety and depression. How do we best treat it? Because traditionally, when we think about the treatment, right, through a pill, right, Ativan for anxiety, or like a drug for depression. But actually, now there's accumulated evidence that mindfulness-based intervention can be a really effective way to manage both anxiety and depression. That evidence quality is actually rated as high. The strength of recommendation is also high. So why is it particularly relevant to patients with Lynch syndrome, either before cancer diagnosis or after cancer diagnosis? Because for a lot of patients at risk for cancer with genetic syndrome, there could be like this heightened anxiety, right? Like you really worry about what's next, what would happen, right? So anxiety is an emotion that is sort of evolutionary necessary, right? Anxiety make us to study for our tests, make us to prepare for our talk, so make us to probably achieve a little bit better in life, right? But then too much anxiety can be really a problem for our health, right? It can really diminish the joy of life, make us not focus what's important, but really consumed by the anxiety. So mindfulness is a technique really help you to ground in the current sensation and letting intrusive thoughts pass, acknowledge, but don't over dwelling on that. It's a really important skill to learn so you can effectively cope those anxieties, whether they're associated with family, work, or scans, or like diagnostic tests or treatment. So I always tell cancer patients, if you see anxiety as a wave, right? You visualize yourself as a surfer. You can let anxiety crush you, or you can surf gracefully with anxiety. Our goal is not to completely eliminate anxiety in our life, is really learn the skills to manage it effectively and gracefully, right? Certainly depression can be also very common. Actually, with the pandemic, the mental health is another pandemic, really affecting United States as probably the rest of the world. The latest data suggests 1 in 5 people have clinically significant depressive symptoms. That's a lot higher than before. So again, mindfulness or yoga or music therapy can be potentially really helpful to address that. Again, we do this in conjunction with our psycho-oncology colleague, whether when it's appropriate to use psychotherapy, when it's appropriate to use drug, but there are non-pharmacological ways we can help you. So one of such way is called the integrated medicine at home. I know there's over 100 people participating in this workshop. Many of you may live far from Manhattan. Some of you may be even outside of MSK, right? So this is a virtual resource that is available to you wherever you are. Actually, we have people from 23 states and 3 countries participate in our programming. So what it is the live classes. We have 23 live classes spread out through 7 days a week. So you have live instructors, teach fitness, teach dance therapy, music therapy, meditation, yoga, or Tai Chi. And often in a group setting, the class could be 10 people, the class could be 100 people, right? So people are really engaging in their health, engaging their body and mind in a very active way and building a community to support each other. I would say this program is particularly important for if you're young and healthy, you like to go to the park to exercise, go to gym to exercise, good for you, continue to do that. I think our program is particularly helpful for patients going through cancer treatment because I just saw a patient today, even you can be incredibly healthy or doing a lot. Sometime after just another round of chemo, you're just completely exhausted. Then you start moving. If you stop moving for a day or two, it's no big deal. But for some people, they just end up never pick up back their exercise. So then this is a program to really help to keep you motivated, provide you a structure, provide you with that social support from other patients to help you maintain active. So the biggest difference we see in any cancer prevention or cancer outcome studies, saying the study follow a cohort of thousands of cancer patients, the biggest benefit is actually not comparing a marathon runner than somebody is just doing moderate physical activity. The biggest benefit is from a sedentary person to actually doing some physical activities. So if you're one of those people, you tend to sit around a lot, you just don't like I always tell my patients, there are two kinds of people. There are people who cannot get enough exercise, then there are people I couldn't pay them enough money to exercise. If you're in the second category, I think this could be a really good program to help you provide a structure and motivation. And here are some of the words from our patients, right? We did a qualitative interview study. So we identified three major themes. One is promote positive health behaviors. So this patient said, yeah, it's great because when I try to exercise on my own, it's not regular. And this keeps me regular. And when someone on the other side encourages you to move or say that you can't do it. So I got a love letter from a patient. She was saying, I had so much trouble with my knees. I was never able to walk without canes. Now with doing your program for 3 months, I threw away my cane. I'm able to walk. I'm just so grateful, right? So again, if you could imagine this patient doing on her own, she would never get there. But because there's a structure, there's a expertise on the other side, there are other patients motivating. I'm so proud of her. She did it, right? Then there's other patients saying a lot of time, the problem that you have all those racing thoughts, this class has really helped you to focus on the current session as a way to alleviate stress, enhance coping. Last but not least, a patient, I think the communities are really important. You're connected to the community of some fellow patients you happen to see attending the same session. This provides a platform for people to continue to interact with each other. Often when you diagnose a genetic syndrome or you are dealing with cancer, you really feel very lonely that experience, right? But in reality, that journey of cancer is shared by hundreds of thousands of people. So we need to find ways to help us to connect each other, to use that positive force to connect, to turn our fear, turn our worry, turn our uncertainty into positive force to help us all committed to do something healthy for our lives. So we also developed this sort of a mindfulness library on our website. You can access the mskcc.org/meditation. This could be really helpful, whether you're newly diagnosed or you are treatment or you're getting scans or in survivorship. So you can go to our content. They're very specifically designed to cope with the psychological experience at different phases. So I would really encourage you to try that out. And what about herbs and supplements? So here's the challenge. There is a lot of complex and confusing information on the internet about herbs and supplement, right? So our approach, we develop a consultation to really help patient to make an informed decision based on the clinical context, where you are with the illness, disease. Do you have specific needs that can be improved or addressed by a herb, right? Then we look at where the research evidence, either from basic research, clinical trials, retrospective studies, because this research in this area is definitely more limited than drugs, right? Then last but not least, we really try to incorporate patients' preference and values to really allow patients to be an active component in that decision making. Because sometimes in my experience, you just tell patient nothing works, go, don't take anything. Patients often can feel incredibly being dismissed. I do think this is an area we got to use more thoughtful communication with our patients. And so we actually did a research. We found that when patients go through that kind of consultation with an integrated medicine provider, 80% feel like it's incredibly important to discuss this. And 86% also really enjoyed getting the herbs from MSK. We have a small herbal dispensary to prescribe patients with some herbs that can address common symptoms associated with cancer treatments. and then 85% would like to recommend. In the middle of the pandemic, we also had like a home delivery system that patient was also able to find helpful. So this is a really important resource for the patients. And then there's sort of a QR code you can sort of get to the website. You can also download our app called About Herbs. So this resources we have very dedicated pharmacists as well as science writer to curate the literature about what are the current scientific understanding about the herbs and where are the clinical trial support evidence of the lack of it. So since its launch, we have 35 million internet hits from 12 million unique visitors. Our apps have already had over 300,000 downloads. So we have 292 monographs about specific type of herbs. So here are some example, right? So we have turmeric, or also known as curcumin. It's a very popular supplement, right? So there are some data on the use of curcumin, for surgery to improve, sort of appetite, right? And then there's also some topical application to improve radiation dermatitis. But then there are also some potential side effects such as GI, allergic dermatitis, and so on and so forth. So again, I would encourage you, if you have a friend or family recommend you take a herb, instead of just Google, because Google you will find a lot of information are prepared by herb company in the process of trying to sell the herb, right? Here you can see like a more unbiased sort of interpretation where the information is, and you can make a decision on your own whether you want to take it or not. And certainly you should talk with your oncologist as well. So I would say when you are asking your doctor, say, is there anything I can do? I actually feel like there are quite a bit of things you can do to help prevent cancer and improve your cancer outcome should you be diagnosed with cancer already. If you're cured, then definitely improve the survivorship outcome, right? Number one, in terms of diet and nutrition, I do think it's really important to emphasize healthy food categories and avoid obesities. Have more plant-based diet. Mediterranean diet is a type of diet. It's both pretty tasty as well as not very restrictive, and it has probably the strongest evidence in cancer prevention. Physical activity is key for both healthy aging, for cardiovascular health, and also is associated with reduced cancer risk in breast, endometrial, and colorectal cancer and gastric cancer. So again, those are association studies, not causation, but I think the evidence is compelling enough since there's very low risk. I would highly encourage you to find a way to make those things part of your lifestyle. And I would also encourage you to think about using mind-body therapies, such as acupuncture, massage, meditation, Tai Chi yoga. Should you experience symptoms associated with treatment or anxiety or insomnia or depressive symptoms or pain, those can be important adjunct to your current medical treatment for those symptoms. And last but not least, I think when you think about herbs and supplement, natural does not always equal safe. There's actually data showing with certain type of chemotherapy and radiation, for example, very common herb antioxidant high dose vitamin E can potentially decrease the efficacy of the cancer therapy. So you definitely don't want to just blindly take herbs or supplement during cancer treatment. Unfortunately, there's not a single herb have shown specific efficacy in preventing cancer. So I would take any sort of a cancer prevention herbs with sort of some caveat to really evaluate the needs, whether to do herbs and supplement rather than going to a more balanced nutrition as a whole food prevention. I feel like there's definitely seem to be more evidence towards that way rather than relying on a single high dose supplement. I want to thank you for your time, and I really want to engage with you more during the Q&A section.
Thank you so much, Dr. Mao. That was really, really terrific. So many useful pearls, and I love all the everything that our MSK patients have access to. It's really wonderful, and I've referred patients to it actually multiple times. So thank you for that. It's such a wonderful resource for our patients. And so we have Lisa back. Lisa, do you want me to try to share the slides?
Yeah, I think that'd probably be best.
Okay, perfect. So give me 1 second. And I'm going to go to how does that look? Okay. So again, thank you, Lisa, for being here.
Yeah, thank you. Sorry for the technological issues, but today I'm going to talk about updates on menopause and also women's health. And next, what I'm really going to focus on is really discussing what is menopause. I spend a lot of time in my clinic talking about it. I also spend a lot of time talking about hormone replacement therapy because there's a lot of information out there from 40 years ago that things are much, much better now today with better medications and treatment. And also the most recent updates on women's health in the context of Lynch syndrome. And the other question that I get a lot is because I see patients pre and also post-surgery risk-reducing surgery is what can you do now to prepare for the potential risk-reducing surgery? So menopause is a transition. Every woman will go through it, and it's a natural event. It's defined by the final menstrual period, and it's 1 year of no menses, so no blood. And what is happening is that the ovaries are basically almost shutting down, and once it's a permanent cessation of menses, and this is definitely part of the natural aging process. And most women in the United States will be in menopause around age 52 years old, which means that since now we're living more longer, we're going to be living about 40% of our lives in menopause. So natural menopause is what I pretty much was talking about. It could take 5 to 10 years. So a lot of women, even though the final menstrual period would be around 52, they may start to have symptoms, hot flashes, night sweats, like more like in their early 40s. And that's just like a transition. And that's the natural menopause. The body just kind of modifies and just gets used to all of these changes. Early menopause is defined as the final menstrual period before the age of 45. And then premature menopause is the final menstrual period before the age of 40. And so just like Dr. Liu was saying, when we're talking about risk-reducing surgery and depending on when you decide to do your surgery, these are pretty much almost like the ages. And so there's a lot of concerns around that time. But it's not just surgery. Women do go through early and premature menopause because of genetic factors. Maybe it's a family thing, polycystic ovarian syndrome, such as PCOS, autoimmune disease, infections, surgery, and also medical treatment. However, in my clinic, we do talk a lot about induced menopause. And so this is menopause, not just only just the surgical removal of the ovaries, but I do see patients that have undergone chemotherapy, radiation, they're on tamoxifen or other estrogen blockers, aromatase inhibitors such as anastrozole, and also the GnRH agonists such as leuprolin. But natural and also induced menopause, we have to think about it as very different experiences and also treat it appropriately. So all women will experience menopause, but every woman's experience is actually very different. So the classic symptoms, kind of like what I was saying, there are changes in your menstrual cycle. Maybe your periods 1 month will be a little lighter, another month may be a little heavier. And also, but this is all normal within the perimenopausal stage, but with patients with Lynch syndrome, it's kind of like almost like we really need to really hone in to see, okay, what type of bleeding are you having? Is it longer than usual? So in my clinic, I always like to document, okay, so if a woman with Lynch syndrome, her normal menses is, let's say, 4 to 5 days, I would say if your periods now are lasting more like 8 days, 10 days, and it's a lot heavier, even within your normal menstrual cycle, that needs definitely some intervention, or at least, you need to let your healthcare provider know. Vasomotor symptoms, most women know about hot flashes, night sweats, which is usually accompanied by chills, sometimes anxiety, and sometimes when women are having these hot flashes, night sweats, they have heart palpitations. Vulvovaginal symptoms, some painful intercourse, sexual activity, sexual touch. So there might be some discomfort there. And also there's a lot of now research on psychological symptoms that now are related to menopause, which could be more depression, anxiety, moodiness, and also other symptoms would be cognitive concerns, memory, concentration, and also joint pain, dry eyes, and also the change in weight distribution. So a lot of patients say, oh my God, I had surgery and now all my, I have extra tissue and more fat in my abdominal area. So unfortunately, this is all very normal. And I am going to talk a little bit about what we could do to help. So early and premature menopause, we do have major concerns about it because women that do have these decreased estrogen within their blood system, research has shown that they experience decreased quality of life. There's increased risk of fracture, heart disease, diabetes, and other medical concerns. And given their age, they need replacement therapy. And so the risk of hormone therapy use after the natural menopause really do not apply. So I have patients in my practice, they say, well, my mother, my sister told me that, the medication that I'm on is a little bit too high. And I always have to explain that, depending on their age, whether they're 35 years old, whether they're 42 years old, is very different than a woman who is now 55 years old, because our bodies definitely need estrogen for many of these concerns. And like I said, HRT is used up to the natural age of menopause. So when women go through risk-reducing surgery, so let's say they're about 42, 45 years old, I would say the guidelines definitely do say that hormone replacement therapy should be up to the natural age of menopause or early 50. And then after that, we try to taper down the dosage. I do want to stress, though, that with the hot flashes and night sweats, they are accompanied by sleep disturbances. And by not having appropriate sleep, this has been strongly associated with decreased quality of life, mood fluctuations, memory, obesity, and also research is showing that there may be associated with greater risk for heart disease. So it's really important that women are treated appropriately with the appropriate doses of hormone therapy, have their calcium for their bone health. Like Dr. Mao said and other presenters, the importance of exercise. We need to screen for medical issues and also fertility counseling and also mental health services. This is all really important. It's really tough going through menopause, but just know that you're not alone. And it's really important that you have a healthcare provider to help you, support you through this process. If you are a candidate, systemic HRT, and systemic is medication that is usually by mouth or by a patch that impacts your whole body. So I am going to talk more in the next couple of slides, the difference between that and localized therapy. And like I said, it should be up to the age of 52. Younger women need higher doses to relieve their symptoms and protect against bone loss. And again, more and more research is really looking at how HRT is reducing cognition and dementia, heart disease. And also it's really important to have improved sexual function and also vulvovaginal dryness. So, but there are a cohort of patients, unfortunately, that cannot take systemic HRT. So those women who should not have systemic are women that have unexplained vaginal bleeding, liver disease. They may have a cancer that is estrogen sensitive, such as breast cancer, endometrial cancer. Maybe they had prior heart disease, stroke, heart attack, a blood clot, or maybe an inherited high risk of having a disease that predisposes you to blood clots. So again, systemic is your whole body, but localized therapy is something that most women, it can pretty much have. Low dose estrogen therapy is the vagina alone. It is considered safe. And even in our breast cancer patients, a recent journal article just came out in 2024 that showed that there was no evidence of increased early breast cancer specific mortality in patients who use vaginal estrogen compared with patients who did not use vaginal estrogen. So in my clinic, I do go over other alternatives. And then if in speaking and also in collaborating with their oncologist, more and more oncologists are saying that a little bit of estrogen in the vagina is fine. So this is just like a picture of what the vagina looks like. Just go back. So in a woman who has estrogen, as you could see from the picture on the left-hand side, it's well estrogenized, it's very plump, it's flexible. This is, we call it rugae, so it's nice and flexible. And those women that don't have estrogen, the vagina is just very almost pale, and it's not very flexible, hence the reason why sexual activity could be very painful and uncomfortable. So this is just a really busy slide. Just to say that there's many, many ways of treating vulvovaginal dryness. There's creams, there's suppositories, there's rings, there's even now oral medication. And so again, the guidelines is just as the most appropriate and the lowest effective dose of hormone replacement therapy consistent with the treatment goal. And it's all based upon symptoms, health history, and risk factors and personal preference. We usually do like to do oral transdermal. Actually, transdermal is more like my preference because it's go through the skin. It bypasses the liver. And so according to the research that has been done in the past, oral medication have been associated with increased blood clots. And if you're bypassing the liver, it may decrease your risk for blood clots and also other potential issues. So for women that are not candidates for hormone replacement therapy, there are non-hormonal prescription therapies for hot flashes. There's paroxetine that has been FDA approved like many years ago. But now this year of January 2024, there's a new medication called fezolinetant. And really, this is a new class of medication that really impacts the brain. And so there more and more research are really looking at where hot flashes are actually originating. So they really do, more research is being done more on the level of the brain. And this is non-estrogen. So for many patients that where estrogen is contraindicated, this may be an option. We have been using off-label use antidepressants such as escitalopram and also venlafaxine. We've been using that for our breast cancer patients for many years. Again, this needs to be a nice conversation with your healthcare provider when putting on antidepressants. Adverse effects may include uncommon suicidal thoughts and just have to be very careful. Gabapentin is another medication that has been used for seizures that could help also with hot flashes, and also oxybutynin. Also, it's used for treatment of overactive bladder. And so this is also something that could be used for hot flashes as well. So other things that you can do besides medication is cognitive behavior therapy. So there's many research studies that show that this has a high level that can help with hot flashes, clinical hypnosis, and also mindfulness-based interventions. So this has been very effective in reducing hot flashes, but also behavior modifications to minimize hot flashes. So dressing in layers, avoiding triggers, whether it's spicy food, especially alcohol, caffeine, cool ambient temperature. And they're now again looking at weight loss. Losing some weight can also been able to help with hot flashes. And just like what Dr. Mao had said, there are limited clinical trials evaluating supplements and lack of government regulations to ensure purity and safety. So I have a lot of patients asking me about vitamin E, all the black cohosh. I just have to say that, you have to be very, very careful. So there's some chemoprevention, that women can use for decreasing their risk for both ovarian and also endometrial cancer. I know Dr. Liu did speak a little bit about it, but studies after studies are showing that combined oral contraceptives, birth control pills, decrease both ovarian and also endometrial cancer. And there's also the progesterone IUD. There's also other IUDs that are a lot smaller, but for shorter use. But Mirena IUD has been on the market for a very long time. This is definitely shared decision making and based upon your needs, whether it's contraception, and also being able to prevent also these cancers. This is a discussion that you need to have with your healthcare provider, because you really need to also talk about your risk for breast cancer. So lifestyle modifications, just like Dr. Mao said, I mean, patients always ask, what else can I do? And I always tell patients, you can't change your DNA, but you can change your lifestyle. And healthy diet, increase in your activity, so studies after studies are definitely showing that this can help, not just for cancer prevention, but I also talk about heart disease, and also it's very good for your bone health and also for your mental well-being. So it is recommended about 150 minutes per week. That's about 30 minutes per day, let's say. That could be broken up for 10 minutes in the morning, 10 minutes in the evening, especially for my busy moms, and about 10,000 steps per day. It's also really important to eat a variety of nutritious foods and really try to minimize processed foods. I usually tell patients, if you look at the label, if you see a paragraph, and it basically is all chemicals that you cannot pronounce, the body doesn't know what to do with that, with what you're actually ingesting. So it's really, and basically what the body does is just puts it into fat. So it's really important to eat just regular healthy foods. So a diet high in fruits and vegetables, or whole grains, and also oily fish such as salmon. Minimize sugar sweetened beverages, and also salt intake. You want to don't smoke tobacco, secondhand smoke, vaping, and also limit alcohol. The Canada did just come out with guidelines to say that no amount of alcohol is considered safe. In the United States, it's still now moderate. So I just tell patients, just really just watch how much you're drinking. And also you could drink and also eat your water. There's a lot of foods that we eat that actually contain water, such as cucumbers, peppers. I mean, there's watermelon. I mean, we all know this. And just pay attention when you go out to eat. Just try to eat most of your food at home, but just when you go out to eat, just look at portion size and also the trans fats. So there's a lot of research that needs to be done. I think that's one of the things that we've learned through this workshop is that, but also in the realm of women's health, and also especially in women that have genetic mutations such as Lynch syndrome, what is the most effective hormone therapy for optimal patient satisfaction and prevention of long-term morbidity that's associated with estrogen deprivation because of premature menopause. And the optimal regimen for one individual may not be the same for another. So it's really hard to replicate the magic of nature. So these conversations of when to have surgery is really, really important. And also more studies, like I said, need to be done in our Lynch patient population. We need randomized control trials and also data registries. So what can you do now to prepare for risk-reducing surgery? Again, even if you're in your 20s or 30s or in your 40s and you know in the future you're going to be having surgery, look at your lifestyle. If you need to lose weight, get on a program that you actually like. If it's Zumba, if it's walking, if it's yoga, whatever it may be, just do something, just move. Cancer prevention strategies, eating healthier, just really looking at what you could do yourself to give yourself control. And just take care of yourself. Take walks, strength training, yoga, meditation, reducing stress. And if need be, consider speaking with a menopause expert. There's a North American Menopause Society, and I have here the website. If you, depending on where you live, you could put in your zip code, and they'll be able to give you a list of healthcare professionals that have actually taken the time to actually be an expert in this area. Review your medications, vitamins, whether it's fish oil. Again, just like what Dr. Mao said, really be careful what you're having and just don't take something because your aunt told you to take it. And also get your home ready. I always tell patients, before you go and have surgery, have somebody clean your house, or clean your house, have your children help you, because the worst thing to do is to come home and then your house is a whole mess. So set up a recovery area with your books, phones, and all your drinks. And also be kind to yourself. Give yourself grace. It just gives you time just to heal, whether it's physically and also emotionally, because this is a life-changing event. And you're not alone. Ask for help, lean on friends, your family, and there's a huge community, whether here it's MSK, but also around us. So please reach out. So in conclusion, hormone therapy differ for women, depending on the type, dose, duration of use, the route of administration, and also the timing. Treatment is completely individualized. These are very nuanced conversations. So also just use the best evidence that's available to maximize benefits. Your experience with menopause is influenced and can be changed by other factors such as your lifestyle, environment, and medical history, and also how you believe based upon your culture. Always discuss your options with your healthcare provider, and just know that you do have the power in your everyday choices. Thanks.
Sorry. Thank you, Lisa, so much. That was really great. And it actually very nicely complements Dr. Mao's talk as well. So thank you. So we are just going to take 10 minutes if you're able to stay on for a few questions. So I'm just going to ask our panelists to come on camera. And then I'll take a few questions. Dr. Liu, I think there was a question that, let me just see where it was. I think it was in the Q&A. For you on, sorry, let me just look it up.
Self-injectomy, I think. Is that the, yes, no, that's a great question and something we talk about a lot. So, I think the origin of self-injectomy as a way to, prevent ovarian cancer probably originated in the more typical type of ovarian cancer, which is the high-grade serous. And we see that type more associated with our patients that have BRCA1 and 2 mutations. And the reason that we think that removing the tubes, either ideally before the ovaries, or in lieu of the ovaries, is effective is because the hypothesis is that the ovarian cancer actually comes from the tip of the fallopian tubes, and removing the fallopian tubes potentially could remove the risk of ovarian cancer while still allowing women to keep their ovaries and natural hormones for as long as possible. This is still, it's very interesting, but it's still very early. There's actually a lot of randomized or clinical trials going on right now to kind of look at this and see if it's effective and safe. Currently, the gold standard is still to remove both the ovaries and the fallopian tubes, but for women who aren't ready to remove the ovaries yet, it is possible to, do the tubes first. I do think, there might be some benefit. It might be a little less in patients with Lynch syndrome because the mechanism of the ovarian cancer is a little bit different, although there could potentially be some benefit. And that's why, we have a lot of very long conversations in clinic about, the timing, like Lisa was saying, of when to do the hysterectomy. We generally recommend women do this after they're done childbearing, but no earlier than 35. I will say most women sort of think about this in their late 30s, early 40s. And oftentimes that is very early to think about going into menopause, even with all the resources that Lisa talked about with hormone replacement therapy. So more and more we're having these discussions with women of, well, if you're not quite ready to remove the ovaries, let's do the uterus and the tubes, knowing that we'll probably go back for the ovaries. But right now the gold standard is still to do both. But it's a great question, and it's definitely something worth talking about and asking your providers about.
Thank you so much. Dr. Mao, there was a question about NAD+, the enzyme.
Yeah, I think this is a very, I'm going to use this example to talk about supplements. Often, if you look at literature, there are some basic signs saying this is in a pathway to either treat cancer or prevent cancer. Then you will see in the supplement website, this is cancer prevention, this is the best thing, right? So unfortunately, doing research from animals or from cells to mice, then to higher level animal, then to human is a very long and arduous process. A lot of those compounds eventually end up not necessarily be helpful, and in many cases can be very harmful, especially when enzyme targeting enzymatic pathway. Often it can have beneficial effects for some aspect of health, may have detrimental effect for other health. So I would be very cautious of taking those as supplements, especially for cancer prevention purpose, because we just don't know the net benefit or harm. Because there's actually multiple large randomized trials show when you're taking vitamin-rich food in the population is associated with cancer prevention. then you pick out whether it's vitamin E or you pick up a carnitine. It actually ubiquitously showed it actually caused more harm than benefit in the randomized trial setting. So that's why we want to make sure we emphasize taking those nutrients in the form of food rather than relying on a magical bullet approach because we just don't have the evidence. And again, through trials after trial, the result typically is pointing the other way.
Thank you. Actually, that's very, very helpful and very good advice all around. Lisa and Dr. Liu, there's a question about hormone replacement therapy for a young woman who is in her early 30s, postmenopausal, estrogen versus progesterone versus combination, especially as it relates to cancer risk with this. In Lynch syndrome, I should say.
You want me to take it?
Sure.
Yeah. So a lot of it, Lynch syndrome, I'm assuming her uterus has been removed. For women that have had their uterus removed and also fallopian tube and ovaries, as per the guidelines, only estrogen is recommended. There's been a lot of discussion in talking to my patients about progesterone. There's also discussion about testosterone. Regarding libido, it's one of the things that I wanted to talk about in my presentation, but that's like a talk in and of itself. And this is a definite conversation. It's very nuanced to have with your healthcare provider to see what you actually need. But estrogen replacement therapy is what the guidelines actually recommend.
And then I'll take the next question. It's about, is there a best colonoscopy prep? So I have to say, I did ask a gastroenterologist this question once, and they said the one that works, which is a very GI-like answer. So most of the combinations of preps that are used these days involve polyethylene glycol, which is something called Miralax is one common source of it. It used to be, and the way that it works is this PEG molecule is just not absorbed from the colon. And in fact, through osmosis, it takes in a ton of water. So you do need to drink with it, but not as much as you needed to drink with the older school Go Lightly, where you have like the huge jugs. So with Miralax, you can get a lower volume prep. And oftentimes they do combine it with like laxatives like Dulcolax. I have to say that each gastroenterologist and each group has their unique combination, but I've had patients where you need to change the routine prep to something else if it doesn't work, you know? So I think it's important that if you know you have a slow transit time, it just takes you longer to clear out your bowels, to start the prep in plenty of time, with starting a couple of days before with clears or at least liquids and then moving to clears. I think that's a lot easier on your body in some ways, and then starting the prep as you're prescribed. So I think that can help, but there's no one magic prep for all per se. Dr. Latham, there's a question about cfDNA and whether we should be doing it along with colonoscopies, which I thought we should probably address. What's research and what's clinical?
Yeah, so someone had asked that in the chat, and I would say that yes, there are commercially available tests that doctors and healthcare providers can order out in the community, but I can't stress the importance that these do not replace gold standard screening tests such as colonoscopy. And in terms of the false positive rates or the false negative rates, we are still learning about these. So I can't comment on what an individual practitioner may order in their clinic, but I would just use caution to make sure whomever is ordering this knows how to follow it up and has a plan for you in the event that it is a surprise result.
And then we'll have one more question that just came in. Does cancer risk increase or remain the same for someone in early menopause due to pelvic radiation or chemotherapy? Is there a benefit or disadvantage of keeping the reproductive organs that are not functioning?
I can take this one. I think it depends on the situation. I just want to make sure I'm understanding. presumably if this is someone with Lynch syndrome with a gynecological cancer, the treatment often involves surgery and removing of these organs. But there are situations where patients may have other cancers like breast cancer and undergo chemotherapy, and that might push one into menopause earlier. And if there is an inherited risk of gynecological cancers, I think there is still benefit to removing those organs because it's not necessarily the function, it's the tissue that's at risk for cancer. So I hope I'm interpreting that question
And
correctly.
I think with rectal radiation, we see this quite a bit in young women. And even though the reproductive organs may not be functioning, you still need to remove them for cancer prevention. Yeah, it's a good question. And I think those were, I'm going to ask my panelists to look quickly if there are any other ones. There are a lot of questions about the slides. So this is being recorded and the videos with the slides will be available hopefully within a month or so. So it will be posted on our MSK websites. If you have any questions, you can directly email me at stadlerz@mskcc.org. Matilde, maybe you could put that into the chat while I'm looking at the other questions, just so the attendees have my email address. And I'm going to look at the chat questions really quick. I think we answered most of them. Yeah, I think we did. Lots of interest in the cfDNA study, and please again reach out to us via email, and we can get you plugged in on the appropriate clinical trial for those. So I just want to thank everyone for attending and for taking out a night from your lives to be with us. And I especially want to thank our panelists for being here tonight and for answering the questions and giving really terrific talks and overviews of what are really complex topics. So thank you. And please don't forget that you will be receiving the survey in about 3, 4, 5 days. And please fill that out so we can use that to plan next year's event. And we wish you a very, very good night. Thank you.